All right, why don't we go ahead and get started as folks filter in for our neurology lecture series talk. We are honored to have an epilepsy talk today from Dr. Wolfgang Muhlhofer on the localizing value of seizure semiology. A little bit about Dr. Muhlhofer. He couldn't remember the name of the grade school, but he did tell me the name of the high school, which is Dietrich Bonhoeffer Gymnasium, which is in Heidelberg. And he then stayed on in Heidelberg to finish medical school before coming stateside to do his residency at Rochester University in New York, a fellowship in epilepsy or neurophysiology at University of California in San Francisco, and then a master's in science and healthcare simulation at the University of Alabama in Birmingham, where he was also on faculty for 6 years before coming to the Northwest to the University of Washington, where he's now on faculty. I was telling him that he's seen more of the US than most Americans have. With that, I turn it over to Dr. Muhlhofer.
All right. Thank you so much for the kind introduction, Sandeep. Yeah, it was interesting to move across country multiple times. Family has grown since then. So I hope everyone can hear me okay and can actually see my slides.
Yeah, we're good. I think we can hear him. Yeah, we're good.
Okay, great. I was just kind of scouting out who was logging on to this presentation and then this session, and it looks like I see some names that are definitely within the epilepsy division, or neurologists that are epilepsy trained. I assume there is all levels of neurology trained personnel on this call. I really tried to keep this a kind of a broad overview that hopefully will be helpful for all neurology providers out there. Certainly, as you go into the nitty-gritty of seizure semiology and localizing value, you can read textbooks after textbooks, and people create whole careers over this. So if I omit anything that is being felt significant here to the discussion, I please, for any of my colleagues, chime in and fill in those blanks as we go. In terms of questions, we will have questions hopefully in the chat that I'm probably going to address at the end of this talk. There'll be some time to ask questions at the end of the talk as well. If there's any pressing concerns or technical issues, like you don't hear the video or the audio, just let me know, unmute and let me know, and then hopefully we can troubleshoot. It shouldn't be an issue because we just checked it. So with that, just want to make sure, since it's a CME talk, I have no disclosures. And these are kind of our objectives, so we're going to try to cover today. We really at the end of this talk, want to be able to identify some cortical and subcortical structures that are relevant for seizure generation as well as spread, discuss the difference between seizure onset and symptomatic zone, which is important when you try to conclude from a semiology back to localization in neurology. We want to try to apply some of the terminology that's commonly used to describe seizure semiology, and then utilize seizure semiology to hopefully adequately lateralize and localize seizure onset zones, and based on the history and then some of the recordings of the seizures that we can see as part of the workup. So this is obviously a view of the brain, and what you see here are the numbers of the Brodmann areas that have been sort of described and have been utilized to really not just anatomically describe the brain and the cortex, but also functionally. And when I talk about seizures, I always make sure to kind of have sort of this concept and idea that seizures or epilepsy primarily is a disease of the cortex, especially when it comes to seizure semiology. So knowing your anatomical landmarks is one thing, knowing the frontal, parietal, temporal, and occipital lobe, but then also knowing the functional regions that are within these lobes is important to kind of make sense of the seizure semiology as well. So obviously here you have the central sulcus, you have the precentral gyrus with the primary motor cortex, you have the supplementary sensory motor area, the frontal eye fields here, as well as in the dominant hemisphere, Broca's. When you go into the parietal lobe, you have the postcentral gyrus with the primary sensory findings, sensory gyrus. And then we have in the temporal lobe, the Wernicke's region, as well as the primary auditory cortex and Heschel's gyrus. And we have primary and secondary visual areas in the occipital region. Now, also one thing to keep in mind is the motor and sensory homunculus that you see that the predominance of the convexity really for both sensory and motor modalities is face and hand. And then we have the representation of arm, shoulders, trunk, and leg that sort of goes into the interhemispheric fissure. At the same time, we also have larynx, pharynx, and some of the more cervical structures in the so-called perisylvian fissure and the operculum here, which again is something to keep in mind when you hear certain descriptions of symptoms or you see certain symptoms. Now, there are also portions of the cortex that are kind of hidden and that we don't see necessarily in the lateral view, and that includes when we look through the sagittal view here, the structure that is right above the corpus callosum, the so-called cingulate gyrus, which is a structure that really spans from the frontal or parietal all the way to the occipital region. And then obviously our fifth lobe, the so-called insular lobe, which is again sort of buried under the frontal, parietal, and temporal operculum. Now, the cortex is the harbor of the neurons that have hypersynchronous firing, which eventually leads to the seizure and the seizure semiology itself. But that by itself is not enough to kind of really explain as seizures progress. And so it really comes down to also what structures facilitate seizure spread. There are obviously local mechanisms like synaptic transmission, gap junctions, and short U fibers that facilitate regional spread. But then you also look at the really big white matter bundles that connect both hemispheres or connect very distant areas such as occipital lobe all the way with the temporal or the frontal lobe. And these bundles are obviously very, very important to keep in mind if you think of areas in the brain where seizures might not cause symptoms, but then very well could spread into other areas that are becoming symptomatic. And we'll get through that concept in just a bit. Now, the other network that is important for seizure spread and gains more and more interest in terms of research and intervention in terms of neuromodulation, kind of trying to facilitate, to kind of affect this network and network spread is the so-called limbic system, which basically includes the PACE circuit, right? Starting in the parahippocampal gyrus, going through the fornix, into the memory bodies from there, and into the anterior nucleus of the thalamus, and then back into the cingulate gyrus. Now, that is certainly something that we always consider for spread patterns that come from the mesotemporal lobe structures, but also the other way around from other areas of cortex that then secondary focalize in the temporal region, which we call for that reason also temporal lobe mimics. And then there are deeper structures that do affect, or can cause, epileptiform discharges and seizures. And we're thinking about the thalamus as being one of the hallmarks here for primary generalized epilepsies and these bifrontal central discharges that we see. And that's also one of the reasons why, neuromodulation devices such as the vagus nerve stimulator that does have sort of retroactive influence on brainstem nuclei that then project into the thalamus, that this entity is actually working. And for the deep brain stimulation, for example, the only FDA-approved target right now is the anterior nucleus of the thalamus, which is, as I said, part of this limbic network. So these neuromodulation devices kind of harness these deeper structures to modulate networks that generate seizures and then facilitate seizure spread. Now, seizure spread patterns and times are a little bit, dependent on where they start. This is an interesting paper that is now already, 11 years old. But what they actually ended up doing was they looked at intracranial EEG recordings on patients, 40 patients with a total of 112 seizures, and they were looking at the onset area or seizure onset zone, and then the preferred propagation of these seizures. And what they found was that, for example, a mesofrontal lobe seizure had the predilection of spreading to the contralateral mesofrontal region, more so than, for example, to other ipsilateral structures, while, for example, the dorsolateral frontal cortex had more of a spread pattern to the ipsilateral temporal region. The same for the orbitofrontal starting point. It was more likely for the orbitofrontal to spread into the contralateral orbitofrontal region or the ipsilateral temporal region. The mesotemporal lobe kind of structures, they interconnect a lot with each other. So a contralateral mesotemporal lobe spread and pattern was also more common. And then interestingly enough, lateral temporal would also spread into orbitofrontal regions and contralateral, but parietal region preferably spread to either ipsilateral temporal lobe, dorsolateral frontal region, or occipital region, and then occipital region more so also into the ipsilateral mesotemporal lobe structures. So again, seizures can start very distant and then spread into other structures that are much more prevalent in terms of causing seizure semiology or seizure-related symptoms. And then the other thing is to keep in mind is the spread time. So when we look at spreads from these regions, looking at ipsilateral spread versus contralateral spread, for example, in mesofrontal seizures, the contralateral spread was much faster than ipsilateral spread. So we're talking about, within less than a second, right? 600 milliseconds. So it's a very rapid, what we call secondary bisynchrony and spread pattern, which makes frontal lobe seizures so challenging sometimes, especially in the mesofrontal region, to really lateralize and localize. And then you basically have a seizure semiology that affects both hemispheres at once. And then you have a hard time kind of putting that sort of putting, kind of organizing your thoughts around that. Now, when we talk about seizure zones and zones of the epileptic cortex, if we say hypothetically there's an epileptogenic lesion here, like a tumor, for example, and there is typically an irritative zone, which is the area where we see epileptiform discharges, whether it's on the brainwave test or EEG or other modalities such as the magnetoencephalogram or MEG. And within those typically overlapping epileptogenic lesion and the irritative zone, there is what we call the epileptogenic zone. And the epileptogenic zone is the region of the cortex that can generate epileptic seizures. And if you remove this area or disconnect it, then you should be seizure-free. And so interestingly enough, this epileptogenic zone always includes the seizure onset zone, but typically slightly more tissue around it to really grant seizure freedom. And then based on these kind of electrophysiologically active zones, you have the so-called ictal symptomatic zone. And ictal symptomatic zones, depending on where the seizure spread, can be different, right? So if a seizure spreads into the adjacent, for example, parietal lobe region here in the primary sensory cortex, you might have primary sensory symptoms. If it does spread down into the temporal region, lateral temporal region, and the dominant hemisphere, you might have more of a Wernicke's aphasia. Now, these are two very distinctly different symptoms that come from an area that is actually not really in the areas where the symptoms are displayed. So that's sort of the idea that a symptomatic zone doesn't have to overlap with the epileptogenic or seizure onset zone. And really, the best guess that we can have based on the seizure semiology and the history that we can take are the auras, are the warnings, the prodromes that patients would describe. These are the areas that we think of as symptomatic focal seizure without impaired awareness, so the patient can still percept the changes and can describe them. That is probably the closest to the seizure onset zone. It might overlap. It might be in the neighboring cortex or an area that is distant to this, but is well connected with sort of white matter bundles. So this is a concept that we always have to keep in mind. And that's also one of the reasons why we pay attention to onset of clinical symptoms versus EEG onset when we monitor these patients, because there can be a delay depending on where things start. Now, the other thing is to kind of think about latencies between electrographic and clinical onset and propagation, depending on where things are. This study here was looking at intracranial recordings of 43 patients, total of 215 seizures, and they were looking at median latencies between electrographic onset and early propagation, and with that also delay in terms of clinical symptoms or onset of clinical symptoms. And the main areas that they observed or looked at were the frontal region, the temporal neocortical, lateral temporal regions, as well as the mesotemporal structures. And what they found is kind of summarized up in here, that the latency between spread and clinical symptoms was the median time was much lower, like 6 seconds on average in frontal lobe, compared to neocortical temporal, where we were looking at 17 seconds, and then mesotemporal, where it was up to almost 20 seconds. And we kind of take that into consideration when we think of seizure semiology and asking them, so do you secondary generalize? In other words, do you have a generalized tonic-clonic seizure? And if so, how long does it take to get to that point? How long does it take for the seizure to spread outside of the area that originally started in? And so we think of the mesotemporal lobe and orbital frontal regions as areas where seizures can hang out for minutes on end without secondary generalizing or spreading into other structures. So that can be sometimes a clue to help you as well, kind of organizing your thoughts. Now, so how do we know things about seizure semiology and what areas seizures are coming from? Well, a lot of this is sort of reverse engineering, also based on the literature that we know from lesions. From tumors, strokes, we know that certain areas, if they are, get damaged, the patient is displaying certain neurological deficits. So that's one way to kind of assign function. The other way that people have done is sort of exploration is to reversibly disrupt physiological function of certain brain regions. For example, using transmagnetic stimulation or electrical currents to really see if we can reproduce sort of a defect for a transient period of time if we target a certain area. We do this in the epilepsy world on a fairly regular basis as we implant these electrodes, either subdural grids or depth electrodes. After we've done sort of our monitoring for seizures, we do restart patients on medications and then systematically map these regions with electrical currents and sort of test the patient, see do we have certain deficiencies, and how do these or active positive symptoms, and how do these match up with the patient's symptoms that they have during a seizure. Then, a lot of times we can also look at the brain regions and see which ones are affected by the seizure electrographically and see what the patient is doing clinically. That can give us also a little bit of an idea, even though that's something to take with a grain of salt because we only see what we implant, right? So if we see seizure activity in this areas at the same time as the patient is displaying the symptoms, we might not have covered the contralateral side or deeper structures that might also be affected at the same time. And then probably the safest way to kind of get an idea of how things might be related is to kind of record record a seizure, stimulate a seizure yourself, identify the epileptogenic zone, and which is not necessarily always the symptomatic zone, but if you then resect and you're seizure-free, you're probably really good in terms of your localization based on these features. So this wouldn't be a simulation, semiology talk without any videos of actual seizures, right? So this is a patient that presented with an aura that typically initiated with a right-sided numbness and tingling paresthesias. She would then sort of have dysarthria, kind of muffled speech, and then eventually some difficulties expressing herself prior to the loss of awareness. So I hope that this plays with audio. So the patient obviously says she's having a seizure, so she has a clear aura. She's feeling something. She hands over the phone and says, "Hand my hand," so her language is already off. So here you see how she's having some fidgeting movements with the left hand.
Left arm in the air.
The right hand is what we call dystonic. The patient is acknowledging nursing, but maybe just having a left gaze preference. She's not following commands. And she's kind of relaxing here a little bit, and they want to get ready and making sure that she's not having a grand mal seizure. And then she kind of comes out of it.
Sure. You're fine. Thank you very much. You're welcome. Okay. About to get.
Now, seizure semiology doesn't just stop there, right? It's sometimes helpful to also, pay attention to what the patient can or cannot do right after a seizure. In other words, post-ictal deficits can be helpful to kind of lateralize and localize seizure function as well. So in this case, they are actually doing a follow-up sort of assessment, and you might want to pay attention to that as well. Oh, sorry, I'm gonna jump ahead. Here you go.
Fine. Yeah, you're welcome. Okay. About to get her up to walk. Haven't done it yet. Hi, can you say your name? No, not yet. Sweetie, can you raise your right arm? Very good. Okay, serve it as. Can you show me 2 fingers on your left hand?
I hear her. Can you hear her? Wait, she talk. What'd she say?
Can you show me 2 fingers on your left hand?
I can't understand.
No. Where's your left hand?
Where's my left hand?
Good. Can you show me 2 fingers? Very good.
So in this case, the nurse is doing the right thing. She's asking, simple commands to really test comprehension, language comprehension. You could also do naming as a very sensitive test to check, for language dysfunction. But that's something you should always kind of do after a seizure, right? Just as you would look for post-ictal paralysis, a weakness, maybe even post-ictal neglect. In this case, the patient seemed to have some language impairment. She actually seems to be initially not able to communicate or express or state her name. She seems to have some comprehension, but then also says that she claims she can't hear well, which this patient is not hard of hearing. But this is actually part of the post-ictal aphasia that she's displaying, which is kind of more on the order of a transcortical aphasia. And when we look at her MRI scan, this is her MRI scan, and you can see this sort of cystic lesion that is actually in more deeper seated structures, the frontal operculum, actually extratemporal. and then sort of extending into the insular region. And interestingly enough, her seizure semiology and as well as the electrographic pattern with the head turn to the left, the hand automatisms on the left, the contralateral dystonia is actually fairly well lateralizing and localizing to the left mesotemporal lobe structures. But that's not where her seizures started. Her seizures actually started in extratemporal and then probably propagated into that region. And the sensory changes that she was having, the right-sided sensory changes, might have been more in the close proximity to the primary sensory cortex in the parietal region. And so this is sort of a classic idea of like seizures can start extratemporal and then can secondary focalize in that area and sort of display temporal lobe semiology. Now, the temporal lobe is epilepsy is very much our bread and butter epilepsy. It's the most common focal onset epilepsy in adulthood. And when we think of the temporal lobe and seizure semiology, we also have to keep the limbic system network and the PAPE circuit in mind. Since the temporal lobe, mesotemporal lobe structures are well connected, also into the orbitofrontal region versus the uncinate fasciculus. And then we have in the lateral aspect, the temporal parietal occipital lobe junction and opercular insular region. So all of these regions can display some symptoms. When we look at the actual functional anatomy, when we kind of test these regions with stimulation, you see that there is smell and emotions, but also episodic memory, visual, spatial recognition, music recognition, and hearing. A lot of these structures, if you have a seizure there, you're not going to test to that degree to really, find out certain type of symptoms. But they tend to be rather, clinically silent initially, and then they have to spread into other regions to really form those symptoms. Now, the main distinction that we really try to do with temporal lobe is, are we having a pure mesotemporal lobe or a lateral temporal lobe onset versus what we call temporal lobe mimics that do tend to spread from other regions. And so if we think of, for example, characteristics in semiology between meso and lateral or neocortical temporal lobe onset, in terms of auras, we tend to see more emotional, viscerosensory, and psychic experiential auras, such as the epigastric rising sensation, déjà vu, jamais vu, feeling of strangeness, and this abrupt onset of fear and panic. That tends to be more mesotemporal lobe versus when we think of old, like sort of intrusive memories, ringing, buzzing in the ear, or voices, which are more auditory hallucinations, or visual hallucinations, which can be fairly well-formed, or distortions of the surrounding, we think more of lateral temporal lobe involvement. As the seizure progresses with mesotemporal lobe structures, we tend to have early orolingual automatisms, which classically goes with ipsilateral manual, fidgeting, picking, rubbing automatisms of the hand, and contralateral dystonic posturing, and then a late progression into clonic activity. With lateral temporal neocortical seizures, we tend to have this motionless stare, early loss of awareness, and then these inconsistent automatisms and dystonia that are not as well lateralizing. And then we tend to have an early spread into the suprasylvian opercular region, which gives you this contralateral clonic activity. In terms of the duration, in terms of also duration towards sort of the progression to secondary generalization, we tend to have prolonged seizures with delayed and less common secondary generalization in mesotemporal lobe structures versus a shorter duration and quick and a more common secondary generalization of lateral temporal regions. Now, moving on to the next sort of set of seizures here. So this is a lady that was actually, I think, some part of some drama group, and she received a lot of complaints by her neighbors that she would be acting and practicing her lines in the middle of the night and being all dramatic. And she came in because she had a generalized tonic-clonic seizures as well that weren't very well controlled with medications, and she went through monitoring. In this case, we captured one of her spells out of sleep, which looked as follows.
Hello. Hi. All right, we'll press the button for you.
I also did
I'm just gonna uncover you, okay? Can you tell me where we are right now? Can you raise your right arm?
Which one?
Your right arm.
Raise it?
Yeah.
So, usually I would quiz people about this, but really what happened here is this happened out of sleep. Pretty much all of her seizures happen out of sleep. And what you can see is this loud vocalization, this grimacing, the gestural behavior that involves both arms, sitting up, laying down, having this fearful, frightened expression. That was sort of her semiology, and it was very consistent. Every time she would wake up and have this sequence of these motor behaviors. Now, this is another gentleman that did not really have any warnings with his seizures, and when he went into one, this is what typically happened. So obviously, this patient fell out of bed and is continuing to have wildly thrashing, kicking motor movements or behaviors on the ground, and then he goes into the sustained tonic posturing with this very pale and cyanotic face and this very gradual versive head turn to the left. Right arm seems to be extended and then goes into the sort of generalized tonic-clonic phase. It's fair to say that this patient here had not much of a postictal state. She was able to interact and follow commands right away. Here, this gentleman was obviously wiped out after the secondary generalized tonic-clonic seizure. But really, both of these are actual representations of frontal lobe epilepsy. And I mentioned here that the frontal lobe is also the big lobe because it is one of the biggest lobes in the brain, and it has a lot of real estate that we typically don't cover very well with our scalp electrodes, and especially interhemispheric fissures and interhemispheric portions, cingulate portions, and orbital frontal regions, and the lateral convexity. A lot of areas here that do a lot of are very much affected in motor planning and sort of executive function. But not necessarily causing a lot of active symptoms until the seizures spread into more pertinent regions. So when we think of frontal lobe, we think of the somatosensory, secondary somatosensory area, motor area, which is in the sort of receiving a lot of input from the primary motor cortex and the parietal lobe. In terms of helping and thalamus in terms of helping motor and sensory coordination. It does project into the spinal cord and the superior colliculus and reticular formation. And it interestingly has bihemispheric representation. The classic sort of kind of semiology here is the Spencer posturing, when the head would turn and the arm extends to the contralateral side of the seizure, and the ipsilateral arm is sort of flexed. But then we also have thrashing motions or bilateral sensory symptoms from seizures coming from this area as well, because it does have bihemispheric representation. The other aspect is the frontal eye fields, which does receive input from the occipital and parietal region, and then projects them down to the family nuclei, causing as it is activated contralateral tonic gaze deviation, which again, along with versive head turn, can be a fairly well lateralizing feature. We have obviously the Broca's area here that could receive input from the temporal region, the Wernicke's region, and then projects into the primary motor cortex, and with expressive aphasia being sort of an isolated feature. And we have the orbital frontal regions here, which do receive input from the thalamic region, but then also project into the temporal lobe, and we can see olfactory hallucinations, and then as the seizure spreads, temporal lobe semiology. The other aspect that is interesting is this gray area here, which are actually considered negative motor areas. And that means that when we stimulate these regions, we elicit an inability to move ipsi and or contralateral limb on these regions, which is just fascinating because we always think of seizures as being this positive phenomenon causing positive symptoms. But if you can theoretically even come up with seizures that do originate in certain regions that would, cause loss of function as well. And I think that's a very interesting concept to think about. Now, when we think about frontal lobe seizures and semiology, some clues that you can get in the history is they tend to cluster a lot of times in nighttime in the first half, which happens because of the non-REM being one of the main trigger factors. They're short in duration, really less than a minute or half a minute, and they can frequently involve these bizarre hypermotor semiology and vocalization, which is one of the reasons why they are commonly misdiagnosed as PNES or behavioral outbursts in patients that are, have some cognitive impairment or developmental delay. They can have bilateral involvement, as I said, with an inability to respond, but not necessarily a loss of awareness, of postictal confusion, like we saw with this lady that got assessed right after this sort of very dramatic outburst. And then we know that parts of the frontal lobe are not necessarily eloquent cortex, but they can symptomatically become symptomatic if they spread into other regions. One of the more classic sort of very localized and lateralizing features are these very focal clonic activities of limbs that almost always tends to localize and lateralize to the contralateral primary motor cortex. And then we have these worsive head turns and Geist deviation that we see as the seizure secondary generalizes, which is usually a pretty good marker that things have started in the contralateral hemisphere or have at least come from there. Now, this is another interesting, actually pediatric patient I saw in fellowship. And what they did was during their neuropsychological testing, they would hook patients up to EEG to make sure that there is no seizure activity interfering with the cognitive testing and kind of get sort of a better idea, how accurate the testing is. And what this girl here had in sort of the task to look at the picture, use the words, and then write down sentences that describe the picture. And as you can see here, that, the first half of this, you see that the spelling is off. You see that she's only writing using the left part of these lines, and then things improve over time, and then eventually she has a pretty decent handwriting and is solving the task very well. The same thing was with copying the figure array here, trying to really, very detailed, kind of following these concepts. Actually, I think she did still a pretty good job, even though she actually had a seizure during this. But what actually, in her case, was the limiting factor was, a focal cortical dysplasia in the left parietal region, occipital parietal region, and she was having active parietal lobe seizures during this, which led to actually an ictal neglect. Again, a negative motor symptom, a negative clinical symptom that you wouldn't necessarily expect with seizures. So seizures don't always have to generate positive symptoms in this case. So the parietal lobe, I call it the neglected lobe because we don't necessarily tend to think of it a whole lot unless we have primary sensory changes, which is a reasonable thing to consider because it harbors the primary sensory cortex. But one thing to keep in mind is that it is also well connected, the superior parietal lobe with the frontal lobe, as well as the inferior parietal lobe with the temporal region. And we have input from the occipital region, the temporal region, and then have sort of also spread from the primary sensory region. So it is a well-connected small lobe that's surrounded by all the other lobes, and so we need to consider it really also as a differential if we have a non-lesional case and we think some of the semiology looks more frontal and temporal, but then there is something funky in terms of the electrical field that we see on EEG. Now, when we stimulate certain regions, we can have painful sensation, paresthesias. We can even see vertigo, head and eyes deviation, and sensory of movement from like in visual hallucinations, complex arm movements. So you can see a lot of different things as you stimulate regions in the parietal lobe. Part of this might be because of secondary spread, but part of this is also because it does harbor a lot of higher cortical secondary and association cortical functions. So if we think, for example, of somatosensory symptoms, tingling paresthesias starting in face and hand, often sparing the trunk, we think of contralateral postcentral gyrus. Even though there we can also have bihemispheric representation and can be rather diffuse peri and postictal neglect, contralateral superior parietal lesion, like the case that we just looked at. Postictal acalculia and language disturbance, again, can be dominant hemispheric parietal lobe. And then a lot of times when the parietal lobe, inferior parietal lobe, spreads into the temporal parietal occipital junction, you can have all kinds of funky kinesthetic illusions and feelings of room spinning vertigos without nystagmus. You can have dysmorphic body features, hyper and hyposchematica. And I even had a patient that was describing his only seizure semiology was that he had a third limb growing out of his chest and being draped across his body. And that was the so-called phantom limb. It's actually a thing that can be also associated with parietal lobe seizures. And then some patients do describe this dysmorphic features of the environment, feeling things are much smaller than they should be or much larger, the kind of Alice in Wonderland phenomenon that we can sometimes see. Now, this is another case that I thought was interesting. It was, again, a pediatric patient, and this kid was very anxious and nervous to go to sleep because every time he was about to fall asleep, he would start seeing these glaring red eyes staring right at him. And the parents thought this was all nightmares and we're kind of sort of going down that direction until he actually had a secondary generalized tonic-clonic seizure. And what actually ended up happening was when he was hooked up to monitoring and had one of these events, he did actually have seizure activity in the occipital region. Predominantly the right occipital cortex. And so he was actually having occipital lobe seizures. When we think of the occipital lobe, interestingly enough, we always think, okay, well-formed hallucinations, that must be occipital. But when we think of the primary occipital lobe, and as we stimulate, we actually have very elementary visual changes, such as changes in darkness and color, or like just colored lights or flashing lights that show up in the contralateral visual field. And that's what the boy saw. He saw actually some red dots. That's all he saw. And he was just putting everything around it, like these are glaring eyes looking at him. But the one thing we should keep in mind is as these occipital lobe seizures progress, especially the meso-occipital lobe regions, which can be fairly clinically silent, they can spread via the inferior and superior longitudinal fasciculus into either the temporal or the frontal lobe region. So we can have seizures that start in the occipital region, maybe even EEG negative, that then secondary focalize into these other areas and make it look like a frontal or temporal lobe seizure. Now, these are some other drawings of patients that have occipital lobe seizures. So you see colorful dots and shapes in one hemisphere. And so it's very elementary hallucinations. You can have ictal blindness. Sometimes you can have eye movements and eye blinking movements. The complex visual hallucinations are more that you see more in the lateral spread into the temporal parietal occipital junction and the temporal lobe involvement. And you can have some tonic gaze deviation contralateral to the seizure onset zone along with that as well. And as I said, the spread to the temporal and frontal region. Now, lastly, this is a patient that, that had a lot of subjective symptoms. So displaying anything in particular wasn't really beneficial. But what he described was he had this abrupt onset of throat tightness, shortness of breath. He felt like it was suffocating and felt really nauseous. Then he would start hyperventilating, feeling panicky, warmth and tingling sensation around the mouth that quickly spread throughout the rest of the body. And then he would lose awareness and be unresponsive with sort of a facial distortion and dystonic posturing of the right arm. And what he actually ended up having was non-lesional case was having left insula seizures. And so, in this case, if we think of the insula being here, like marked in orange, then in this case, this patient had a temporal lobe spread and then some sensory changes that you can see in the opercular region too with these seizures. And when we think of the insula, we can separate it in anterior, mid, and posterior regions, but as well as superior and inferior insula. And, kind of from a functional anatomy, the superior insula tends to be gustatory functioning. So, gustatory hallucinations can happen in these regions where the inferior portion is called gastric mechanical function. So seizures that do affect this area can cause nausea, vomiting, actually ictal vomiting too. And so these are well connected, the insula well connected through the temporosylvian region going into the parietal and frontal lobe cortex, the temporal limbic region, which can spread into the mesotemporal lobe and lateral temporal pole, and then the mesoorbital frontal region. So depending on where the spread pattern is, you can have the superior suprasylvian kind of operculum semiology, which has a lot of tonic, clonic movements of the face, just arthriatic specific aphasia and gustatory hallucinations, versus an infrasylvian operculum spread, which can have primary auditory features as it affects the auditory from auditory cortex and early receptive aphasia. So in summary, we have epilepsy, which is a disease of the cortex, and so localization of seizure semiology does require you to have a decent knowledge of the functional anatomy of the neocortex. We have to keep in mind that the symptomatic zone is not always the seizure onset zone, so you have to consider main spread patterns and connections of certain areas and spread times from other lobes in patients that, for example, have a non-lesional or normal MRI. The lateral temporal lobe seizures tend to have an experiential aura that is more likely to secondary generalize versus the mesotemporal lobe. Orbital frontal insula and cingulate regions can mimic mesotemporal lobe seizures through the limbic network and the local spread. Frontal lobe seizures, they can look very bizarre, as you saw in the videos, and they can come from structures that are not well percepted by the scalp EEG, so it can be EEG negative and can be misdiagnosed as PNES. Key feature here is that they're very stereotyped, brief events out of non-REM sleep without necessarily loss of awareness or retrograde amnesia. One of the classic semiology features for an SSMA seizure is this asymmetric tonic posturing with the Fencher posture, and then primary motor cortex being involved causes usually isolated contralateral clonic activity. The parietal lobe is something that can be harbor a seizure onset that is initially asymptomatic or negative with subtle symptoms. And then if they happen, though, they can be primarily associated with altered perception of your own body or your surrounding environment. Occipital lobe seizures cause more elementary than complex visual hallucinations, and then can spread also quickly to the temporal and frontal lobe regions, which can make this look very much like a frontal or temporal lobe seizure. And then insular and opercular region, they are very closely linked and can be clinically silent, but causing a lot of sort of can cause pain and dysautonomic features, as well as sort of nausea and kind of throat tightness prior to spreading into other regions that could make it eventually look like a frontal or temporal lobe seizure. And with that, I'm pretty much done, and that leaves us a couple more minutes for questions. I know that there's definitely some maybe in the chat. Maybe let me take a quick look at that and
Thank
see.
you very much, Mr. Muhlhofer. And if there are 2 questions in the chat, and if you could read those, that's great. And then if others questions, either put them in the chat or unmute yourself. But you can start with the ones in the chat.
Okay, great. So, so here was a question from Eric Krause, whether I'm using the term aura for focal seizure with retained awareness, and Siri wants to weigh in as well. Sorry. And so yeah, technically that's what they are, right? And they are focal, very focal seizures with preserved awareness or retained awareness that cause symptoms. And the patient is obviously still wide awake and aware to be able to describe them, even though the most common aura is the indescribable aura, the indescribable feeling. And I feel like that has something to do with the seizures are activating the cortex in a very weird way, or activating cortical areas that we don't usually use. And so they generate sensations that we've never experienced before, which we don't have terms for. We can't describe them. So if patients say, yeah, I get this feeling and it's really hard to describe. It's just there, or something is about to happen. I can almost say 100% that this is probably going to go down the road of a focal onset epilepsy. So, that wording is something you can definitely keep your ears peeled for that. Then I should share audio, and I haven't done that. Sorry, Shaheen. My bad. Then here, Ariel Davis said, I know not the focus of today's talk, but because I also think of epilepsy as a disease of the cortex, can you talk more about the role of the thalamus? Just involved in spread propagation or more? And how do thalamic lesions impact epilepsy, if at all? That's an excellent question, because it's very much a field of cutting edge research now, and also treatment approaches. We have started to pay more attention to the thalamus, not just as a generator for epileptiform activity and seizures and primary generalized epilepsy, but also its involvement for focal onset epilepsy. And, I do think that, when you look at that literature, it becomes more and more clear that the thalamus is not just facilitating spread. Or if so, it's definitely a structure that facilitates secondary generalization, more so than anything else. So when we do implant patients with electrodes for seizure monitoring, and we do have trajectories that do reach all the way into the thalamus, which again is a pretty complex structure and has multiple nuclei, and it's not always clear from the implantation scheme where we end up. But we clearly see electrographic activity in that region for a certain amount of seizures almost simultaneously, not quite preceding it, but almost simultaneously. And I've had a colleague out of UAB. He's now Sandeep Pradeep. He's now in Houston, Texas. And he was really researching that a lot. And what he always told me is that the thalamus knows right at the onset of a focal onset seizure whether it's going to secondary generalize or not. So he was able to analyze signals in the thalamus and was able to assign these early signals to seizures that do, secondary generalize. And so at some points, it's definitely a target for neuromodulation, also for closed loop stimulation that hopefully will help prevent secondary generalization of seizures, and with that also reduce the risk for SUDEP. So I do think it's definitely a promising target, and we'll hear more about it. Now, in terms of thalamic lesions and how they impact epilepsy, that is a very good question. I'm trying to remember right now whether I've come across a case that would kind of fit that bill. Maybe Shaheen or some of my other colleagues here at UW can chime in as well. I wouldn't be able to come up with a case right now to really make a clinical call on this. I'm not familiar with the literature in that regard either. I don't know. Does someone else on this call have an idea about this question?
I mean, traditionally, we haven't recorded hypothalamus very often, so it's a hard question to answer. We definitely have had patients who have a lesion in the thalamus, and whether that relates to their epilepsy or not, I'm not sure.
Okay, so okay. Did you target the lesion in those cases, and you didn't record seizures from there? Is that what he's saying?
I don't recall.
Okay, no worries. Yeah, so I'm sorry. I can tell you that when we think of the hypothalamus, right, and the hypothalamic hamartomas, that's a lesion that is clearly epileptogenic and is considered a pacemaker for these classic gelastic seizures. And so yeah, that's a subcortical structure that very well is a pacemaker, and it can cause basically focal onset appearing seizures too. So I think, why not? It could be certainly possible. They are well connected, the thalami. So, all right. I guess we have 5 more minutes, which is always a good thing. But does anyone else have some questions?
One question I had was a lot of the cases you gave were pediatric cases, and is some of the breadth of localization, meaning occipital lobe, frontal lobe, more common in younger and as younger onsets epilepsy than older onset epilepsy, or do you see just as wide range of localization in adults as you do in children?
Yeah, I think that's a really good question. And without knowing exactly the epidemiology of the pediatric patient population, since I'm a primarily adult epileptologist, but I did see these interesting cases during my fellowship at UCSF. So I felt like cherishing them and then bringing them as an example. But I think. When we think of frontal and temporal lobe epilepsy being, not insignificantly related to trauma or head trauma, we probably see that more common in adults, and just simply because of the lifespan. They're just more likely to have these kind of insults. When it comes to pediatric focal onset epilepsies, I think. At the end of the day, it probably from a lesional perspective, like when it comes to kind of neurodevelopmental tumors, we all see a lot of frontal and temporal lobe involvement, but I would not necessarily say that they are prone to have more likely kind of parietal or occipital lobe lesions, and unproportionally high focal epilepsy in those regions. So, but I also have to say I would have to probably take a deeper dive in the literature and the pediatric side to really make a definitive call on that to say.
Okay, thank you. And then it looks like we are out of time. There's a link in the chat box. Please do put an evaluation for today's talk. And you can also consider donating the Neurology Education Fund, which is also another link. But thank you very much, Dr. Muhlhofer, for a great talk.
You were welcome. Thank you for having me. Have a great rest of the day. Bye.
You too.